on when I'm invited.
Yes. I'll do the. Do you want me to do the moderating?
Yeah, you can certainly, you are in fact welcome to it, man. You're the host in any case.
No, no, no. The host is still
We
APHS.
first have Rolf on and then I come on.
Okay. We'll just wait for the other panelists and the other speakers. Oh, we're waiting now for Pradeep. Who else?
No, Dr. Chaube will join later because he's speaking much later. He's got no other role. So he's going to do it later.
We requested all the faculties to join us today, right, for the first day. So Maki, Kuya Maki, Failona, we're just waiting for everyone to come in. And then once everybody's inside, we're also waiting for the participants to sign in. So we have 30 participants. Once the 30 participants are all in, then maybe we can start. So right now we have 3, 4. So I'll inform you once the participants are complete, the 30 participants. I'll stop my video, the video feed of PICAS, and then in my feed, I will run the APHS short video that we prepared. So all the participants will see the short video of Asia Pacific Hernia Society, the officers, the mission vision of Asia Pacific Hernia Society, and the past presidents and the present officers of APHS. Alex, can we run now the video of APHS? Thank you. While waiting for the participants and the other faculties to check in. Thank you, Alex.
How many participants we have? Anil, 33, is this correct?
No, we have 33, Rolf.
Yeah.
Yeah, we have 33, and then we have many more participants as well. So we have some participants from industry, from Medtronic.
Yeah.
Uh,
So
we
altogether
have
something like 60, 70 people, or
maybe around that much.
good.
Maybe around that much. And Rolf, I sent you an email. I
Yeah,
wonder if
I
you'll.
wanted to talk to you about it. Of course, my same feelings. We are happy to cooperate, but we don't share our guts. No.
I think so. This is, I mean, because of the reason that that we have certain unique requirements for this part of the world, and we have
But
made
not only
our.
for this, there is a certain ownership. Yeah. So this
Yeah,
ownership, like a patent, more or less, should belong to you, to us, and APHS, and shouldn't be um, shared in an allowed way. I mean, they can, of course, get the content and do their own thing, but just to copy paste it, that would be a little bit too much.
correct. That's what I feel as well. We can certainly sort of contribute, in our own personal capacities. I mean, in the way that they would like us to, but then to give a pre-prepared lecture or a segment or
Yeah.
something.
Remember, we had the same situation with this organizing company who just recorded everything and came up with the same, with exactly the same lecture slides and everything under a different roof. That is, of course, not possible. And with all due respect to Andrew, but he is a guy who likes to copy paste. I know this. No?
Oh, I see. Okay, I didn't know that about Andrew, so that's good. You warned me.
Now, Andrew also at that point of time in APHS 2018 came and asked, can we use this? Can we use the song? Can we use the logo, etc.? I said, sorry, no, that is not possible.
Yeah. So as long as we are all on the same page, and we can wait for a few more comments
Yeah.
from our
Now,
friends.
I will meet with Ruth and I will pack it nicely, but I will tell her sorry.
Yeah. In fact, we this particular training program has been created as an independent, purely educational initiative.
Yes.
So our friends from industry that want to, in fact, support this and be part of the training program are more than welcome. And we would like to stay independent and to keep this as a purely educational initiative.
And
That's
as you
how.
said correctly, I mean, the situation of education and of knowledge and skills around Asia are different from Europe. So it has been customized to our needs and is not really one-to-one applicable to other places. Furthermore, you know that EHS had applied for an own fellowship, or let's say a recognized specialty in abdominal wall and abdominal reconstruction surgery. So with the aim to have a abdominal wall surgeon with the same subspecialty as a colorectal surgeon or as a hepatobiliary surgeon, leading somehow, sometime from now on, to perhaps a future where you need to bring in another surgeon to close the abdominal wall after open surgery. So that is not our aim in Asia, of course. It's quite different. Whether they will succeed or not, I doubt, because Europe is also very much different from the north to the south. So what might be applicable in UK is perhaps not easily acceptable in Greece.
Yeah, yeah, I can appreciate that. Yeah, for sure. For sure. So we have Maki.
Pankaj.
Do we have Satyan?
Not yet, but I see Pankaj. Pankaj, I was not able to transform the video of the second video for my iPad. It works here on my main computer, so I will do the Zoom from the main computer, but it still doesn't work on the iPad. I tried to transform it in different video media, but still it doesn't work. It must be a different type of video media you have used for number 2 as compared to 1 and 3 and 4. So 1, 3, and 4, they also run on the iPad, the second one not. But it runs on my PC. Little bit weird, but it is what we got. We are starting at 12, is it correct? I mean at 4.
Yeah, we're starting 2 minutes from now.
Yeah.
You know, that is what my time says here.
Yes.
2 minutes from now.
Yeah.
So, Cherry, are you there?
Yes, Prof.
Right. So what? 2 minutes from now, is that right?
Yes.
Yeah. So we start with Rolf, and then you know, they will take it along.
But Prof, we're still waiting for Dr. Satien. He's not
Okay.
yet. And Prof. Chaube.
No, Prof. Chaube will join later because he's not contributing as a moderator or a chairperson or anything. So he's going to join later. Let's not wait for him.
Okay. Just an update. We already have 16 attendees.
I see 23, but this is the total number, right?
Yeah, 23.
Must be.
Including,
And so you mean 16 from the participants in the course?
so yung polling, Dora, ito na bahala.
Can I ask, the participants are mainly from the Philippines or from all over?
Linda, are you
I think
there?
it's mainly in the Philippines.
Yeah.
Yes, Prof. Ralph, they are all from the Philippines, but we do have a few of our Medtronic corporate regional colleagues from India, Thailand, and of course from the Philippines as well, because this is the first inaugural APHS Hernia Essential Basic Online course. And I like to see and support all the president and past president in this program. It's really something unique.
Where's my camera? Here.
That's a good one.
Hi, Linda.
We should do that at the end. Hi, Dr. Maki. We should do that later on when you are thumbs up for a group photo.
Yeah. I can see Ellen is sitting in the sky, more or less.
Yeah, he's dangled in the air somewhere. Oh, he's in multiple places.
Ellen,
Okay,
we proposed yesterday that we put a tracker on you. I mean, in you, better than on you. Somewhere subcutaneous or intrarectal or something like this.
Maybe the surgery in the other hospital.
You're in the car again.
Yeah. We called it previously the intestinator, you know. So you are trackable wherever you want to go. We
I
can
don't
find
in
you.
the other hospital, that's why. So I came in a lot.
How come you are there and there?
You were cut off. You and anyway, it's 3 o'clock. How many participants do you have now? Checked in, sorry,
20.
20. So anyway, we still have the opening and then the speeches with the uh,
Can I just suggest, Alan?
yes,
Do you think we can start on time?
yes,
That's because that's how we've been doing it all the while. You know, the guys who have come on time should not suffer.
I
Why
agree.
should we wait for the others that are late?
I agree.
What do you think?
You
Anyway,
said you said 3 o'clock in the Philippines, isn't it 4 o'clock?
4 o'clock.
4 o'clock. It's
Yeah,
3 minutes past 4 o'clock now. Four
yeah.
minutes past 4 o'clock. Anyway, uh, if everybody would agree, I would like to start the program.
Yeah.
You want to show the program?
If Anil and the president of Asia Pacific Hernia Society would agree.
Yes, I'm with you.
Yes, please.
As usual, I agree.
Okay. So anyway, I'll be moderating for today. Before we start off the program, we would like to welcome everyone to the very first online course of the Asia Pacific Hernia Society Hernia Essentials Basic online course. We're quite lucky, and I think this is a big event, a landmark event for the Asia Pacific Hernia Society. It's the first uh, course that was made online because of the COVID pandemic. We usually would go to other countries and then do the courses in that country. This is also the first time that all the past presidents and the present president uh, is included in one program. We're quite lucky, especially for the participants. All the 33 participants from the Philippines would be having the experience of having all the presidents, past and the present presidents of APHS coming over. Anyway, without much further ado, I would like to call on the welcome address of our present president, Professor Ralph Carlton from Dubai, to give us the welcome address. Rolf, please.
Yeah, thank you very much, Alan, and congratulations on the organization of this first online webinar, Zoom webinar. As you all know, the HE program, Hernia Essential program, has different parts, and there are certain parts which certainly cannot be conducted online because it requires wet lab, dry lab, and attachment to a accredited center of excellence. So therefore, it's the first step here in this program, which we thankfully got from our past president, Anil Sharma. So Anil has introduced this HE program for a specific reason to train surgeons, mainly young surgeons in the Asia Pacific region in hernia surgery. Hernia surgery is definitely the most common and most frequent elective surgery worldwide, and therefore a very important part in surgery. Now, unfortunately, due to the pandemic, we were forced to shift a big part of our educational sessions to the online module. And this has advantages and disadvantages. One of the good advantages is, as you can see here now, all the presidents can easily participate without traveling and be available for you. But the disadvantage is a very important part of our society is the social interaction, the communication, the friendship, which is on the top of our society. And we hope that pretty soon all these travel restrictions will be lifted and we can meet again together. Now, for today, I would like to thank Anil for his initiative to start with this first online HE course, part 1. And I think, Anil, you will explain a little bit more about all the content and the program for the next 3 days, and a little bit about the history of APHS and the development of this fellowship. So thank you very much to all of you for joining us, and yeah, have fun.
Thank you, Professor Rolf Hartung, the present president of the Asia Pacific Hernia Society.
I can take over the Philippines also, no problem.
We're glad to have you as our president, Rolf. Anyway, to continue on the program, I would like to call on Professor Anil Sharma. Professor Anil Sharma is the one who did the Asia Pacific Hernia Society Hernia Essentials program when he was the president way back 5 years ago. We would like to welcome Anil and just to introduce what the Hernia Essential program is and what it is all about. Anil, please.
Yeah, thank you. Well, thank you, Rolf, and thank you, Alan. Well, y'all have just been too kind. You know, this is something that has been put together by the entire Asia Pacific Hernia Society. You know, all faculty have contributed. We've had tremendous feedback from the sort of ex-com members and the office bearers of the APHS, and that's how this program has come to be. So, can you see my slide now? Can I go ahead?
Yeah, we can see.
Yeah. All right. So this is a picture taken on top of a skyscraper in Bangkok. And this seems to have, I think, become now an iconic picture. So this particular training program is then a purely educational initiative from the APHS. And by itself, the APHS is now, got firm roots throughout the subcontinent. We have about 1,400 life members from 46 different countries in the region. And we have 15 national chapters that are affiliated to the Asia Pacific Hernia Society. So this current training program is based not just on what me or Rolf or somebody else thinks, but then this is based on some international guidelines that have been laid down by several different bodies throughout the world, as you can see, starting from Europe to the Asia Pacific to the International Endo-Hernia Society and the Americans also. So this is by and large a collective effort from our global fraternity. Now coming to this training program itself, this has 3 components. The first component is the basics. This is what we are in fact doing today. The second component is the practical. This is spread over 1 or 2 days, and this consists of surgical demonstrations, of endo training, and of dry and wet labs. The third component is the fellowship component of the Hernia Essentials, and this involves participants going to accredited centers of excellence within the Asia Pacific region for a period of 2 weeks. And once you have got these 3 under your belt, you then become eligible for the diploma from the Asia Pacific Hernia Society. So what we in fact normally used to do till the pandemic came calling was that we would do the basics and the practicals, which means component 1 and component 2 together, and then follow it up with fellowship, and then finally diploma. Now, right at the end of this training program, there is going to be a hernia MCQ, okay, 30 questions. And we do need a pass mark actually for you, to be entitled to taking component 2 and 3, and then finally diploma from the APHS. So this is going to happen right at the end of the program. Let's forget about this. Now, we've had 27 previous training programs throughout the subcontinent. We started in 2017, and it's been 3 years now. So the thing about this training program is that this training program remains the same wherever it is held. So be it in Manila, be it in Beijing, be it in Dubai, be it in Delhi, it is the same training program, the same content that is presented, in most cases. But then having said that, we have such a diverse scenario here in our subcontinent that sometimes we in fact need to improvise. So sometimes in countries like China, sometimes in Vietnam, we do have simultaneous translation of slides as well. So this is where we have conducted training programs earlier, and you can see there is a widespread throughout the subcontinent. We have 11 centers of excellence throughout the region that have been accredited by the Asia Pacific Hernia Society. You can see again on the slide, there is, the different regions seem to be quite well represented. Now, the feedback form is something that is taken very seriously by us here at the APHS, because this is what in fact helps us to change, to improve, and to also send feedback to the Royal College of Surgeons. So once we have finished this program, you have done the MCQs, you will then get feedback forms from the secretariat here. And once you have sent back your feedback forms to us, we will then give you a certificate of participation for this course. So we have trained about 1,500 odd candidates so far throughout the subcontinent. And we have so far handed out 62 diplomas in 2 diploma ceremonies. The first was in Bali in 2018, and the second was in Dubai under stewardship of our current president, Dr. Rolf Hartung. This course is, of course, endorsed by the Royal College of Surgeons of Edinburgh, and you will get a certificate of participation right at the end that talks about this. So well, thank you very much for being here again. This particular training program has 2 things in special, like has been mentioned earlier. It is the first online training program, and it is the first time that we have 7 or 8 presidents of the APHS that are here to deliver this training program. I want to thank PCAS, my good friend Alan, for his help, for being such gracious hosts. I want to thank Medtronic, Jeffrey, Linda, and the team. They've been on the ball all through. And of course, they were presidents of the APHS for sparing their time and being here for the course. So it's back to you, Rolf. Thank you very much for your attention.
Yeah, thank you, Anil. Yes, also my thanks to Linda and the team for making this possible. So it's definitely also a first experience for us, although we do quite a number of webinars and Zoom meetings every day. But this kind of online course, which will lead to an accredited diploma in the end, that is, I think, our first experience as well. Now I can see here, thank you very much for bringing this presentation up already. So I will try to...
Excuse me, Ralph. Before we go to the lecture of Professor Martung, we would like to give first the poll for the first lecture. Prior to the poll, I would like to acknowledge the presence, of course, of our present President Rolf Hartung, our past President Anil Sharma, Professor Barlan Soteja from Indonesia, past President again, and Professor Macario Failona, the immediate past President of APHS. We have a poll, right, Cherry, for the first lecture?
Yes, for the first lecture.
Yeah, before Professor Rolf Hartung participants to answer the poll. Can we show the poll now?
Yes, Professor.
Sorry, Rolf, for that.
No, it's fine. I just saw my presentation coming up already. So, great.
Okay, we'll just wait for the participants. Please answer the poll before we move on to the lecture of Professor Hartung. We thought of putting up a poll so that we'll know on how much the knowledge of the participants on this subject matter. And all of these questions actually will be asked on the third day, after all the lectures, just to see on how effective the lectures are and how efficient the introduction of the talks. Okay, so we have the answer to the poll. So this is the result of the poll. The first question is, I need to learn the posterior endolaparoscopic anatomy of the groin. 96% said yes. 4% said no. I am familiar. The second question is, I am familiar and comfortable with the posterior or the endolaparoscopic approach anatomy of the groin. 31% answered yes, and 69% said no. So we have a good, a good number of participants who answered this one. So we go on now. We close now the poll, and we go now to the lecture of Professor Rolf Hartung. Rolf, please. Thank you.
Yeah. Okay. So can I share my screen, or can you see it already?
Not yet, Prof. Can you share your screen?
You can start sharing.
I will go back. Is it there now?
Yes.
We can see it.
Yeah, I will just make it slideshow. Yeah, so yeah, it's interesting to see the results of the poll, and the question was basically from the posterior view, and the first lecture will be on the open view, the anterior view. I think all of you are quite familiar with the anterior view. If you look at this triangle in between the midline, medially, the linea alba, the umbilicus up, the superior part, the outer layer, the superior spine, iliac spine, and the lower end here, the symphysis. then we see this area, the inguinal area, which is having these typical demarcation lines, and the inguinal ligament in between the symphysis and the iliac spine. Now, as you can see here on the slide, and everybody knows this, a very important landmark are the epigastric vessels, the inferior epigastric vessels. They come out of the iliac vessels or go into the iliac vein and are somehow much upper in the abdomen, anastomosing with the superior epigastric vessels. So they divide classically what we call an indirect hernia, the lateral hernia, from the medial hernia, medially to the epigastric vessels, as the so-called direct hernia. If we look below the ligament, below the inguinal ligament, we have the femoral opening, the femoral channel, and this is something where we find the femoral vein, the femoral artery, and a little bit more laterally, the femoral nerve. Important to know is that the inguinal ring is not just a hole, it's a canal. So this canal begins from the inside and has a tract from superior, from the upper part to the lower part, from the lateral part to the medial part, and from the posterior to the anterior. So it's a roughly 4 centimeter long canal. And from the inside, if we look at it later on, there is the deep inguinal ring. And from the outside, and this is for us surgeons during the examination important, the exterior or the superficial inguinal ring. If you look a little bit more at the layers, then you will have here in purple the inguinal ligament as the main structure to the lower end. And then we open layer by layer. So the first layer is actually the aponeurosis of the external oblique. And once opened, we can see the muscle. And if we divide the muscle, then, or if we reach to the lateral parts, and the medial parts it's fascia only, we see the internal oblique muscle. And deeper down, the transversus muscle with the transversus fascia, specifically in the medial aspect, where we talk about the conjoined tendon later on. And from the inside, all this is covered by the transversalis fascia and the peritoneum. In the very middle here, we will find the rectus, the lower end of the rectus abdominis, and then, of course, the linea alba. So below the inguinal ligament, as we said, there is the opening for the femoral vessels. And medially to this, we have the pectineus muscle, or better said, the adductors of the leg. So it's mainly the long adductor and the gracilis muscle, but here in the picture, the pectineus muscle. If we look at this slide with the different layers, you can clearly see now from inside here the internal inguinal ring, and then a canal which in males will have the spermatic cord as content, and in females the ligament, the rotund ligament, the round ligament. And importantly also to respect are the nerves which are running in between the fascia and the muscles. Now, if we come to the medial part, then you can see here that we are talking about a tract, the iliopubic tract, which is down there, and this kind of single layer with the transversalis fascia without any further structures in front. So in front, we basically don't have the internus muscle anymore, and we don't have the external muscle anymore, only few flimsy layers going onto the spermatic cord and following the track down into the scrotum. You can see it here. These are the so-called intercrural fibers, basically, and then at a certain level beyond the external ring, there is no cover anymore. Again, the nerves, very important to respect because, as you know, the recurrence rate is not the only problem. We also have the chronic pain. And if you disrespect the nerves here, basically the iliohypogastric nerve and the ilioinguinal nerve, the genital femoral nerve with its genital branches here, these are the nerves when injured, causing the postoperative pain and what can lead to something like chronic pain, which makes the life of our patients miserable, knowing that most of the patients actually don't suffer of pain before hernia surgery. So this needs to be respected, whether you do open or laparoscopic surgery. Now here another view from the open view after having dissected the aponeurosis, the external fascia. We will see the conjoined tendon medially. Here this is medial, and then we can have an idea where is the internal ring, and we like to measure the size of the defect in the lateral hernia, in the indirect hernia. And in case of a direct hernia, it will be a more or less disappearance of the conjoined tendon here, leaving a hole behind, which is the direct defect. Another view again, just for the orientation. So here medially, you have the symphysis. Laterally up here, you have the anterior iliac spine. And in between the two, the ligament, the inguinal ligament. Now here again, we are talking about something which is a region of a possible origin of a hernia in the inguinal region or in the femoral region, and it can even go down to the obturator. So all this area is a weak area where mainly males might develop a hernia. All of you know that the frequency of femoral hernias is a little bit higher in females. So in males, we have the spermatic cord, which is following the canal here, again, from lateral to medial, from posterior to anterior, and from up to down. So that is an oblique structure, which is about 4 to 5 centimeters long. Now here, a direct view on this, you can see that the external aponeurosis has been cut. Here down here, it is retracted, and you have a look onto the inguinal ligament, and then you see a little bit of fat here and the spermatic cord. And if we look into more details, we will find that a nerve running here, the conjoined tendon here, the conjoined muscle here, sorry, and then a little bit of fat down here. And if we dissect this more, you see the reflection. This is the inguinal ligament. And in open surgery, quite important because this is our fixation point for the reconstruction, whatever fixation you do in mesh, without mesh repair. So in non-mesh repair, you will always fix your structures, whether it is the muscle in Bassini or the transversalis fascia in shoulder ice repair, you will fix it to this structure. So here you can see a sling around the spermatic cord, and you can appreciate already a yellowish structure here, which is maybe the sac already, the hernia sac, in a case of an indirect hernia. And here more in details, you can separate the structure. Then here you can see down here already a little bit separated, and separated by a sling here. You can see the plexus pampiniformis, so the spermatic vessels, mainly the veins, and the vas deferens, the spermatic duct here, while all this is fat and hernia sac. And if we separate this further, you can appreciate that there is, which often is present, a lipoma of the cord. The yellowish part we could appreciate earlier, and a white part, which is the hernia sac with the borders here. So it is clear that we need to dissect the hernia sac from the spermatic cord here and resect the lipoma of the cord as a so-called pacemaker for hernias. I think that has been the last slide. Yes.
Hello. Yeah. Thank you, Professor Ralph Hartung. Just a few reminders for the participants. If you have any questions to Professor Ralph Hartung or to any other lectures, please type them down on the Q&A box. It's shown on the lower right part of your Zoom window. Anyway, we would like to acknowledge the presence of Professor Satyan Tumtavitikul from Thailand, one of our past presidents for the Asia Pacific Hernia Society. Prof, welcome again. Anyway, in the program, we have an open house of about 5 minutes. Because we're late for 5 minutes, I think everyone would agree that we just move on to the next lecture. The next lecture will be given by Professor Satyan Tumtavitikul. But before the lecture of Professor Satyan, we would like to post the poll questions. There are poll questions again. Please, let's put up the question. Again, we would like to ask the participants to please answer the poll. Do we have the answers? Can we post now the answers to the poll? Okay. So the first question is, the classification of hernia for documentation is required. Everybody agreed that we should have a classification of the hernia. Commonest hernia classification in use today, 54% are still using the NIHUS classification. 42% is using the European Hernia Society classification. And a small percentage, 4%, is using the Gilbert's classification. So before that, thank you for those who answered the poll. May we go on now to the lecture of Professor Satyan Tumtavitikul. Satyan, thank you. Satyan, your mic is on mute. Can you unmute the mic, please?
Thank you very much, Alan. Greetings from Bangkok, Thailand. Wish you all well. Today, I'm assigned to talk on two topics. The first one would be classification of hernia. I have no disclosures. Yes, you all answer correctly that we all need classification. The purpose of classification, number one, it's accurate archival of hernias. It's a documentation of the hernia. And secondary is that when we compare different techniques and therapeutic guidelines, we have to compare apple to apple, orange to orange, but not apple to orange. So we need some sort of a unified classification. Classification first for inguinal hernia. There are so many different classifications. As in the poll, I can see that 54% of us today using NIHU's classification, which is very good, which is a very detailed one. But because all the big shots in the world have big followers, so we all come together and they decided that they will use the simplified one, which is very detailed, similar to NIHU's, but then agreeable to everybody. We call that European Hernia Society classification. Nowadays, all the major journals will accept using European Hernia Society. So those who use NIHU's classification, I would urge you to change to using APHS classification because this become a gold standard. Variables in the classification are three. First is the nature, is it primary or recurrent? And second one is the size of the hernia defect. 0 means no hernia detectable. Size 1 means 1 finger breadth or 1.5 centimeter. 2 means 2 finger breadth, and 3 means more than 2 finger breadth. And X means not investigated. And then the third variable should be the site or location of the hernia. Is it lateral, which is indirect, or medial, which is direct, or below the inguinal ligament, which is femoral hernia? And this is the standard. If you look like this, that in the operating documentation, you either circle the primary or the recurrence. And then on the lower scale, there is lateral hernia, medial, or femoral. And then you choose the size and you just tick the one. For example, if it's 1 finger breadth and lateral hernia, you just tick it here and it's primary, then you circle, make a circle on the P. But if it's a recurrence, then you make a circle on an R and you give the diagnosis and the operation type and the mesh used, like polypropylene or whatever, just put it down. And this would be a nice sheet of documentation. You can find this in European Hernia Society guidelines. For classification of ventral and incisional hernia, again, all the experts in the world come and said that we will use European Hernia Society because it's simple and it's detailed. So now it's also become a standard for all the publications. Variables similar. You have location, you have the size, and you have the nature, primary or recurrence. And for the primary, usually it's not so large. So the diameter is small, is less than 2 centimeter, medium is 2 to 4 centimeter, and the large one is more than 4 centimeter. And you have a midline hernia or lateral hernia. For the midline, you have epigastric or umbilical hernia. And the lateral, you have Spegelian hernia and lumbar hernia. And you just put down the size and then you tick on whichever category. And this would be primary abdominal wall hernia. For the secondary or incisional abdominal wall hernia, the midline, there are 5 categories on the midline. There is subxiphoid, epigastric, umbilical, infraumbilical, and suprapubic hernia. These are the midlines. For the lateral hernias, there are 4. Subcostal, flank hernia, iliac hernia, or lumbar hernia. You just put down the number. For midline, it starts with M, M1 to 5. And lateral hernia is 1 to 4. And recurrence, yes or no. The incisional hernia usually are much larger than primary hernia or congenital hernia. So the size, the width, 1, 2, 3, 1 means less than 4 centimeter, 2 means 4 to 10, and whatever larger than 10 is W3. These are the sizes. This is the anatomical diagram. For the midline hernia, incisional hernia, you have subxiphoid, you have epigastric, M2, umbilical, infraumbilical, and suprapubic. And for lateral hernia, you have subcostal, L1 right here, L2 flank hernia, and iliac hernia. And far lateral toward the back is L4 lumbar hernia. These are the classification for incisional hernia. And the measurement, if you have only one big huge hernia, it's easy. You have to put down the width and the length. Use the greatest width as a starting point. If it's a different shape, use the widest one as a width and the longest dimension as a length. What happens if we have multiple hernia? We combine them. And for example, in this diagram, we have 3 hernias. The width is the most lateral to the right to the most lateral to the left. This is the width. And the length is the highest point of the highest one to the lowest point of the lowest one. This is the length. This is what we are talking about. Because the incisional hernia is in between is also very big. So this is how we come up with the measurement of the hernia. Again, you can find this in European Hernia Society literature. And this is the end of the first presentation, classification of hernia.
Thank you, Satyan.
Yes.
Yeah. Thank you, Satyan. The lecture on classification of the hernia. Before we go on, we would like to call again on Professor Rolf Hartung to give the second portion of his lecture, anatomy on the posterior or the endolaparoscopic view.
Should I go ahead, or you want to?
Satyan?
Yes.
Yes. Before we go to your second lecture, we go back to Rolf to give his lecture on the endolaparoscopic view. We missed out on the lecture of Rolf. It's my fault.
Okay, very well.
Back to your lecture again, to your last lecture. Thank you. Thank you, Satyan. Rolf?
Yeah. Can I share?
Yes, you start sharing now we can see your slides, Rolf.
Okay. Yeah, then I was quite pleased to see that the participants have somehow ticked the box that they need to have more information on the posterior view, on the endolaparoscopic view of the hernia or of the inguinal region. Just from my own experience, I mean, I learned hernia surgery more than 40 years ago, and it was, of course, a Bassini repair at that point of time, and always an anterior view. So when we progressed in surgery, then the anterior view became a mixed view from anterior and in between the layers when it came to complicated repair and stopper repair from in front, and when it came to shoulder ice repair. And when endoscopic procedures came up, then at that point of time, we had to relearn anatomy and to look from inside. And actually, like on this picture here, in the beginning of our laparoscopic procedures, we didn't have CCC cameras or on the tip cameras. So we had to bend our backs and to look through the endoscopes like on this picture here. So it's very important nowadays in endoscopic hernia repair that we learn about the view from the umbilicus. So the look from inside and then to repair the hernia from inside, which physically definitely makes sense as the weak layer is on the backside and not the skin. So as you can see here, there is a so-called pre-peritoneal space, which has never been described before endoscopic procedures, and which is a so-called potential space, an artificial space we surgeons create in between the different layers, and mainly in inguinal hernia repair here, in between the peritoneum to the inside and the fascia transversalis to the outside. So this artificial space has to be created, and then it will give you a new view of anatomical structures from the half inside. So there are two different ways how to approach the hernia from inside. As you all know, there's a total extraperitoneal approach, the TEP, and there's a transabdominal approach, which is the TAPP. In the end, the anatomy remains, of course, the same, and the view is the same on the area. But these are two different approaches, and I assume that most of you are more familiar with this transabdominal view because you do already appendices or gallbladders or any other kind of laparoscopic exploration and repairs. So for most of the new hernia surgeons in the field of endoscopic surgery, the transabdominal view is more familiar. We will come to this. So this is a typical transabdominal view. So if you put your scope through the umbilicus or a little bit above here, the umbilicus, you will see this structure when you look into the abdomen, into the lower abdomen. And you can see here, of course, medially in the center, the urinary bladder. On the back side here, the bowel, mainly the small bowel covered with a little bit of omentum. And then you see the structures, basically the medial umbilical ligaments, left and right. And laterally, you see the vessels here. And this is what you see and what you already know. And then here, up here, you can estimate the epigastric vessels. Now, once we have created this so-called space, the preperitoneal space, you will have to dissect downwards. So how we do this, that will be explained later on in the repairs, but we go basically just behind the muscle, just behind the rectus muscle. We open the rectus muscle. We then divide it or push it a little bit laterally, and then on in this space, either by the balloon you have seen in the draft or by just CO2 insufflation, you will create a space. So if you look here at the space, you will see here, down here, the peritoneum. This is the posterior layer. And then you see these spider webs. Is basically a space without a lot of blood vessels. And if you are in the right space, you won't need electrocoagulation or any kind of bleeding control unless you damage some layers, some vessels, or you are in the wrong layer. And then you will dissect more and more down until you will see this whitish structure here. And here you have already prepared almost for a bilateral hernia repair because the symphysis is here and you see the right and the left pubic bone. And in the next slide, the Cooper's ligament. But you can still appreciate all these spider webs, and you have to create this space by dividing those attachments to have a sufficient. So here again, the same. And then we talk about the so-called Hasselbalch triangle, which is the triangle where we expect the weakness here. And you see here, down here, this is the symphysis, down here, the Cooper's ligament as shown in the last picture. And here laterally, you see the epigastric vessels. Again, a different view now from the TEP repair. Basically, this should run. No, it doesn't. It comes in the next. And the spermatic cord, here already nicely divided. So you can always appreciate that the vessels are going up towards the kidney, while the spermatic, the vas deferens goes medially and joins, of course, the prostate, as you know. And here would be the internal inguinal ring. So this is a nice triangle, and we will come back to this later. And in this picture, you can then see that a suture or a ligation is here put around the peritoneum, which has been divided from the spermatic cord. So important landmarks are definitely the pubic bone here centrally in the middle, and then the Cooper's ligament, which is easily detectable. Of course, the big vessels, you can see here the iliac vessels, then the spermatic cord here with the vessels and the deferens duct. Laterally to this space of Bogros, we will come back to this, the psoas muscle. Anteriorly here going up the inferior epigastric vessels. The same view now in a drawing, and again, very important, as I have mentioned in the beginning, there is not only the inguinal region, which might be the origin of a hernia or the place of a hernia, there's also more to it. So looking at the inguinal ligament, in front abdominal part of it is actually the direct and the indirect hernia orifice. The division is given by the epigastric vessels here. Whatever is lateral to the vessels is an indirect hernia. Whatever is medial is a direct hernia. But also inferior to this ligament, you have the femoral hernia, which might come out from here. And then the vessels, of course, the vein, the artery, and not shown here on this picture, the nerve. Maybe this should be the nerve here. So the femoral nerve, also very important, although obviously far away, it can be damaged. So very important to respect these important structures below the ligament. Now, the appearance of the direct hernia is, of course, as mentioned, medial to the epigastric vessels. Here, the epigastric vessels. Here, the Cooper's ligament, so the symphysis up here. Medially to the vessels, there is the defect, the direct defect, which is always the direct protrusion of peritoneum and eventually with content through the weakest point of the inguinal region. This is the sac which has been removed, and then you see the defect here. So looking at the dissection, you will see here the Cooper's ligament, then the symphysis and the dissection onto the pubic bone. And you can see here, up here already, the direct hernia immediately above the pubic bone. So it's almost like the close to the vesicle area. And after dissection and after the pseudosac has been pushed back, you can remove the sac easily from the direct orifice. So you can see here the defect, here the Cooper's ligament and the pubic bone, and the perfect dissection. I think here they are just looking also for more hernias like a femoral hernia, which isn't present in this case. Epigastric vessels, please don't cut into it. Yeah, this would be the example of an indirect hernia, easier to see specifically from a TAPP approach, because you will see the sac following the spermatic cord into a hole which is lateral to the inferior epigastric vessels. So you can see here the inferior epigastric vessels, the hernia slipping into this hole, which is down here with the spermatic cord. And once this has been pulled into the view, you can reduce the hernia, resect the sac, or not, up to the size and up to your skills. So here again, these spider webs, and as you can see, the dissection is bloodless. So if you are in the right plane, there will be no vessels, there will be no bleeding, and it's always a dissection of pulling and pushing, as you can see here. So one instrument is pulling up, the other instrument is pulling down, so that you can dissect this space nicely. And then once you have identified the spermatic cord, you will start to dissect the sac from the spermatic cord. So a few seconds more, you can see here the vast difference. So this part here is the sac, and then you can ligate the sac or dissect the sac. If the sac is still going deep into the scrotum, we would always prefer to dissect the sac rather than to pull everything into the abdomen. That's about the indirect hernia. And then here, the femoral hernia, you can clearly appreciate that this is very low down below the ligament. And you can see here already that the vessels, the iliac vessels, receive the epigastric vein. So it's quite down. You can also see here already veins from the corona mortis. So this is a clear hole below the ligament. Nice dissection deep down to identify the defect. You don't need to dissect this deep, of course, but you need to dissect the entire space so that the overlap of the mesh from here to all sides, 5 centimeters here, 5 centimeters to the posterior side, and 5 centimeters to the anterior side and lateral side, will have a nice space to receive the mesh without folding. Therefore, this extensive dissection. Here, a much rarer hernia, which is even one step more down, which is the obturator hernia. You can see here that this is clearly below the pubic tract, below the Cooper's ligament. So the femoral hernia, as we said, is directly below the inguinal ligament, while the obturator hernia is below the Cooper's ligament. That is on the left side. Here, the hernia inside. Here, the hernia has been reduced and you have full view on the defect. Don't ever miss those hernias in laparoscopic repair. That is something which we called previously a pseudo recurrence. If you repaired a type of, let's say, indirect hernia, and then a few weeks later, the patient comes back with a femoral hernia. We called it as a pseudo recurrence. But in laparoscopic repair and endoscopic repair, that wouldn't be acceptable. Yeah, that is a clear recurrence. Here, a case of several holes, several hernias in one go, lateral, medial, and down, so that will be all covered by one mesh. And this is the weakness or the area of Fruchot, which we have mentioned. So it's the myopectineal orifice. And the advantage of laparoscopic repair is whatever you find, the mesh will cover it all. Here you can see again the rare hernias, the obturator hernia already mentioned before, and you can appreciate the femoral vessels. That's on the right side. So first comes the femoral vein, then the femoral artery. So very deep down, and sometimes you might find some structure here, which can also be lymph nodes. So you have to be careful not to dissect too close to the femoral vessels as there is not only the possibility of bringing damage to it, but also you could cause thrombosis of the femoral vein by applying too much heat. Now, what are the two spaces we are looking at? This is the preperitoneal space, Neuhus, and we have medially the retius space and laterally the Bogros space. So when we look at these spaces and you have dissected your medial space, so means here the retropubic space, the bladder behind the pubic bone in front, and this is the part you start your dissection with. So you always start with your medial part because you want to identify your landmarks, and your first landmark, as shown in the slides, will be the pubic bone. So once you have identified the pubic bone, you can just complete your dissection here to open up the retius space, to be then continued by the lateral dissection, the Bogros space. So you can nicely see here the backside with the pulsation of the iliac artery, the defect here, which is clearly a medial defect, and the retial space here. So this space actually needs to be dissected. And if you don't dissect far enough on the posterior aspect, you might have a high recurrence rate. This will be then followed by the lateral dissection. During your journey from medial to lateral, you will find two triangles. The first triangle, nicely visible here, in between the separation of the spermatic vessels and the vas deferens, is a triangle which is called the triangle of doom. Why so? Because you can see here the iliac artery and the iliac vein behind, and doom because if you injure those vessels, that is basically a catastrophe. People think it will not happen, but it happens for various reasons, and therefore stay away from these triangles. Also, it is related to the fixation or non-fixation of meshes. So when you fix a mesh, when you feel that the mesh needs to be fixed, never ever put tackers in these two triangles. This triangle of doom because of the vessels, and the triangle of pain laterally here because of the nerves. So this is the second triangle of pain, and you can appreciate the nerves are coming from lateral to medial, or from lateral to down to the leg. So here the lateral cutaneous nerve, which is a purely sensory nerve, so that doesn't have any motoric function. But if you damage this nerve, the patients will lose their sensation on the lateral aspect of the proximal side. You can appreciate the psoas muscle here, and remember, on the psoas muscle runs the femoral nerve, which then goes immediately lateral here, immediately lateral to the artery, vein, artery, nerve, into the leg, so below the ligament. This triangle is the triangle of pain. So equally to the triangle of doom, you won't apply any kind of fixation devices in this area to avoid tacker-induced chronic pain. Now you can see here now a view on the medial aspect. You can nicely see the pulsation, the collapse of the vein, but you also see these huge veins medially running over the symphysic bone and running laterally, joining here the epigastric vein, coming down from the pelvis with aberrant obturator veins. Classically, this area in open surgery was called the corona mortis, because people died actually in ancient times from hernia surgery because of a bleeding due to the laceration or the injury of those significant veins. Nowadays, we are talking about the Bender-Witt circle. So you can see here that significant veins are in this area. I don't think that they really expose you at a risk to damage them. But once damaged, they are quite difficult to control. And there can be also a backflow from the iliac vein out of those veins. So you will suddenly have a quite significant gush of blood in your field, which shouldn't happen. So you can appreciate the video again. That is clearly to be avoided, this area. So once you have dissected this, it doesn't really matter, place the mesh nicely, but take care if you use tacks not to put the tacks by mistake through one of those veins. Now, what are the take-home messages from the posterior view, anatomical view? So first of all, this newly created preperitoneal space is a potential space you have to create. So it's in between the rectus muscle medially and in front, and the fascia transversalis anteriorly, and the peritoneum to the posterior side. So pay attention not to damage the peritoneum, because your air, your gas, will then go into the abdomen. So if you do a TEP. In TAPP, it's a little bit easier, because you come from the abdomen and you will dissect the peritoneum away from the anterior layers, so that you can place your mesh, with the end result to place this peritoneum over the mesh and to suture it back to the anterior abdominal wall. So two different approaches, which will be explained in the further lectures. Furthermore, anatomical structures to be dissected and identified, as mentioned and shown. The first one is the pubic bone, and then by this, once identified, the creation of the radial space. Then you will go laterally over the Cooper's ligament. Anteriorly, you will respect the inferior epigastric vessels, and posteriorly, you will dissect the spermatic cord. And with this, most of the times, also the sac, the hernia sac, at least in a case of an indirect hernia, to end up with your dissection in the lateral space of Bogros, just to have enough space to place your mesh. So that is the end of my presentation.
Thank you, Professor Ralph Hartung, for the lecture. Before we go on to the next lecture, I would like to, rather than having a open house, I would like to go on a open forum, and let's talk about all the things that were taken up, especially for the anatomy, the anterior view, the posterior view, and of course the classification of the hernia. We have several panelists today. We actually assigned Professor Ralph Hartung and Professor Satyan as our panelists, but we have we have our past presidents, Anil Sharma, past President Barna Suteja, and Maki Failona. I think I lost Maki. Anyway, let's try to discuss the things that were taken up. We also encourage all the participants, the registrants, to please post their questions so we can tackle it up before we move on to the next lectures.
Yeah, maybe one thing to complete the anatomical part. Hernia surgery traditionally has been a teaching surgery. So when I did my first surgeries as a resident, it was always a hernia surgery. And the reason for it was that you have to learn about layers and dissection to respect and to reconstruct the assumed normal anatomy. Of course, in a hernia, the anatomy might be distorted, specifically in a recurrent hernia. But in all those procedures, one common thing is you have to have a very, very clear idea about your anatomy. And this is why the studies of anatomy have to be repeatedly done and reminded, so that any surgeon will not have any problems with anatomy, which is a clear prerequisite before you can start to repair a hernia. Now, in the old times, we did, and in Asia Pacific region, still a lot of anterior repairs are done without mesh. So we need to be very clear on the structures we will unite by sutures or by any kind of repair, whether this is a simple repair or a double layer repair or a repair with release of tension. There are so many different procedures available versus the completely different dissection in terms of mesh repair, because here the aim is not to close defects, it is to put a substitute for the fascia which is gone in place, and this substitute has to be in the absolute right layer. And as I tried to explain to you, if you are in the wrong layer from the beginning, you will face a hell of problems, not only bleeding, but also loss of air into the abdomen, etc. So you have to learn to respect the anatomy and to dissect in the right layer.
Very true, Professor Rolf. There's a question actually here from one of the participants, from Dr. Johan Bagilat. He's our fellow under the UMIST program. And the question is, good PM sirs for Dr. Satyan, how would we classify an obturator hernia using the European Hernia Society classification? Satyan?
Can you repeat the question again? The sound did not come out too clearly.
Obturator hernia classification.
Obturator hernia, how do we classify it using your European Hernia Society classification?
How do we using?
The classification for obturator hernia, Satin.
Obturator hernia,
yes.
Okay.
Yeah.
Unfortunately, there is no classification for that one. That should be, I believe, should be add on. It's not the groin hernia itself. It's inside another compartment. It's a pelvis. I don't know. What do you think, Ralph? Anil?
I can answer this question, yes, because the pelvic hernias, the obturator hernia is considered as a pelvic hernia. The pelvic hernias are not considered as an abdominal wall hernia. So it is beyond the abdominal wall. It's an internal hernia, previously also classified in the group of internal hernias. So there are rare hernias and there is no classification for it yet. Whether this is obturator or ischiotic or hernia after rectal resection or rectal amputation. So this is a specific group. They are out of the standard classifications. Yeah.
Yes. Thank you. Thank you, Satyan, and thank you, Rolf. There's another question from YouTube. Oh, no, from one of the participants. Oh, no, from YouTube. Question came from Dr. Janix de Guzman. The question is, does the EHS classification have corresponding surgical repair technique or recommendations?
Say that again. Does the EHS classification?
The EHS classification, do they have a corresponding surgical repair technique recommendations?
Not really directly, but we use for comparison. Certain people prefer different repair to different classification, especially ventral hernia repair or incisional hernia repair. For example, some would think that any size greater than 10 centimeter considered a huge hernia. They have to consider component separation or whatever. That would be dealt with later on, I think the second or third days, about how do you deal with different type of hernia. But for groin hernia, there are not really relationship, the small size, large size, you can do all anterior or posterior, which I will give a talk today for the next presentation, but it's really not related to the size.
Thank you, Satyan. There's another question from one of the participants. what is the most common cause of recurrence in laparoscopic herniorrhaphy? I think he's referring to inguinal hernia, because the topic today is inguinal hernia. So what's the most common cause of recurrence in laparoscopic herniorrhaphy? The question came from Dr. Alan Sese.
Yeah, that is definitely lack of dissection. Yeah. So if you don't dissect enough, already by desufflation, the mesh will roll up or will fold and will not cover enough space anymore, specifically to the posterior part. So that, I mean, I read here in your question, what is the most common cause of recurrence in laparoscopic herniorrhaphy. Herniorrhaphy, we don't do laparoscopically. Herniorrhaphy means you suture the defect. We do suture occasionally inguinal hernia repairs, but only the pseudosec or we try to block the orifice. But the most important step in laparoscopic hernia repair is not the raphy, it's the plasty. So it should be laparoscopic hernioplasty. Yeah? So if you put a mesh inside, this mesh has to cover the defect to all sides, as I have mentioned, 5 centimeters to all sides. So dissection, very important. But also, if you have a very big defect, specifically in direct hernias, and you choose a mesh which is too soft, or let's say the very lightweight meshes with big pores, then this mesh might protrude into the previous, into the defect and the previously created space. And it will be like a new hernia because the mesh is just replacing the peritoneum as before. So the mesh should be strong enough if you have big defects. In small defects, it doesn't really matter. You can choose a lightweight mesh. In big defects, I would definitely recommend to choose a stronger mesh or a more heavier mesh, which will avoid that this mesh will go into the defect. These are the two main reasons.
Thank you, Ralph. Do you want to add anything, Anil, from Professor Ralph's answer? Anil?
You are muted, Anil. We cannot hear you. You have to unmute yourself.
Yeah, sorry. So yeah, Rolf has talked about most of the situations, that arise that can lead to a recurrence. So like he said, just apart from what he said, the size of the mesh is something that I'd like to state out here, which is going to be stated subsequently. But the size of the mesh that is used should not be less than 15 by 10 centimeters. Okay, by and large, the standard now is, I think, 15 by 12 or 15 by 13 centimeters. But then under no circumstances for a groin hernia repair should you be using a smaller mesh than that. Apart from that, nothing really. So we can move on, I think.
Thank you, Anil. There's another question. I think I just want to ask this as the last question from Dr. Manuel Ramon Santo Domingo, Boji, a very good friend of mine. To Dr. Ralph, do you remove the previously placed mesh that failed before placing a new mesh for recurrent hernias?
That is a very tough question because I cannot answer with yes or no. It depends what do you choose. So the recommendation of the hernia guidelines in inguinal hernia at least is if you had a posterior approach, you will do the next surgery as an anterior. If you had an anterior approach, let's say Liechtenstein, you will go posteriorly. In those cases, no, you wouldn't remove the mesh. But I have seen recurrences with up to 5 meshes over each and every single mesh, there was another one. So at a certain volume of mesh, yes, I would remove the mesh. The situation is different if you choose the same approach. So if you go anteriorly with after a previous anterior approach, or if you go posteriorly after a previous posterior approach, especially if there's also mesh infection, then you would remove the mesh. The situation again is different for abdominal wall hernias in the midline, or in big hernias where you would tend to remove the mesh due to the fact that you want to re-establish a functional abdominal wall rather than a metallic plate in front of the belly. If this answers your question. So it's not yes and no, it depends.
Thank you, Ralph. Thank you. Anyway, let's move on to the next lectures. Our next lecture will be about which hernia repair. We'll be giving some situational uh, on this one. The lecture will be given by Professor Satyan Tavitikul from Thailand, Bangkok, Thailand. Before that, I would like to let's put on the poll. Let's ask everyone again, all the participants, to answer the poll. So the first question is the commonest inguinal hernia repair being performed today. Letter A, open. B, TEP. C, TAPP. And the number 2 question is, a surgeon performing hernia repair today, A, should develop expertise in one technique of hernia repair. B, should be familiar with both anterior and posterior approaches. Please answer the poll. Thank you. So once we reach the maximum, do we have the answer now? Or let's show the answer to the poll. Okay, for the first question, the commonest inguinal hernia repair being performed today, majority of the answers, 71% is open still. I think even in the Asia Pacific area, I think it's still the open. For the endolaparoscopic approach, AAPP, 18% is still higher than TEP. TEP comprises just about 11%. For the second question, a surgeon performing hernia repair today, 96% answered should be familiar with both anterior and the posterior approach. Only 4% said should develop expertise in one technique. I think this is very true. If you would want to be considered as a and would want to go into hernia surgery, you should be at least adept in doing an anterior and a posterior approach. Anyway, let's move on to the next lecture to be given by Professor Satyan Tavitikul, our past president for the Asia Pacific Hernia Society. Satyan, thank you.
Thank you, Alan. My next one would be
you can start to share your.
Yes, I'm starting right now.
Thank you, Satyan.
Which hernia repair? Again, I have no disclosures. Which hernia repair? We have a mesh or non-mesh to choose from. The laparoscopic or open repair. For laparoscopic, we have TEP, TAPP. And then we have individualization of treatment options. Which one do we choose? I see from the poll that majority, more than 70% are still using open repair. And that is still the same everywhere in the world. Even in European countries where laparoscopic is very well used, but majority is still using open repair. For the mesh or non-mesh, a mesh-based repair technique is recommended for patients with symptomatic inguinal repair. This is a very strong recommendation from international hernia guidelines. All the major studies have documented that a mesh is a must in most cases. The use of open non-mesh should be performed in research settings. This has been a standard for many years. It's well documented that mesh is a must. For non-mesh repair, it's documented that the show dies have lowest recurrence rate than other suture repair and recommended in non-mesh inguinal repair. The preferred open mesh repair, there are many techniques. Liechtenstein, Prolene hernia system or Ultra Pro hernia system, plug and patch, self-gripping mesh, and open pre-peritoneal mesh. The recurrence rate and post-operative chronic pain are comparable between plug and patch and Prolene hernia system as well as Liechtenstein. Recurrence and chronic pain are the same. But even with the result, the plug and patch and PHS are not recommended by international guidelines because of the excessive use of foreign material and the need to enter both posterior and anterior plane and for additional costs. That's the reason. The self-gripping mesh for Liechtenstein do not provide any benefit in the short and medium term versus the regular Liechtenstein technique, except it decreased the operative time. For the pre-peritoneal mesh repair, in short term, it have less post-operative and chronic pain with faster recovery. But again, this use up both anterior plane and posterior anatomic plane. In open surgery, there is insufficient evidence to recommend a pre-peritoneal mesh over Liechtenstein. And the use of pre-peritoneal mesh to replace standard flat mesh in Liechtenstein is suggested to be only performed in research settings. These are the guidelines. For laparoscopic TEP and TAPP, both have similar operative times, overall complication risk, acute and chronic pain, and incidence of recurrence rate. All parameters, all outcomes are the same, both TAPP and TEP, no difference. Although very rarely, sometimes TAPP have more visceral injuries because you go into the peritoneal cavity. And also very rare, TEP have more vascular injuries. As you can see from Rolf's lecture on anatomy, you can see many vessels in there that is easily to be injured. And TAPP frequently have some port site hernia because you go directly through the fascia and through the peritoneum. Sometimes you have a small holes that not closed and it can get into a hernia. TEP, the conversion rate is higher because anatomy is more difficult. But the cause, TAPP and TEP are similar. TEP is longer to learn than TAPP. Anatomy is more difficult. For laparoscopic hernia repair, TAP and TEP have comparable outcomes. So the choice would really depend on surgeon's skill, education, and especially experience. What you feel more comfortable. When surgeons have sufficient experience in laparoendoscopic technique, comparing to Liechtenstein repair, there is no difference in recurrence rate, surgical time, and preoperative complications as well as reoperation. All the parameters for the documented literature are comparable. Direct costs for laparosendoscopic repair are higher, but difference decrease when total community costs are taken into account. Learning curve, especially TEP, is longer for laparoscopy than Liechtenstein. And there are rare complications, but serious complications in the learning curve. So laparoscopy technique should be learned in properly supervised manner. For male patient, primary unilateral inguinal hernia, laparoendoscopic technique is still recommended because lower postoperative pain and reduction in chronic pain, provided that surgeons have specific and sufficient resource and the patient and hernia characteristic that warrant a Liechtenstein as first choice. There are some that Liechtenstein should be used. So in other words, it depends on the settings, availability of the settings, the skills of the surgeon, as well as the factors, which is the patient. So we come to so-called individualization of treatment option. For bilateral hernia, it's recommended that laparoscopy is better. For patients with pelvic pathology and lots of scarring, it's better to do anterior approach or open approach. It is recommended that surgeons tailor treatments based on expertise, local resource, national resource, and the patient and hernia related factors. Since generally accepted technique suitable for all inguinal hernia does not exist, it is recommended that surgeons and surgical service provide both anterior and posterior option. So in our survey earlier, I see that nearly 100% agree with this, that we should learn both anterior and posterior. For recurrent inguinal hernia, we use the opposite approach. For example, if the primary repair was posterior, the repair of the recurrence should be anterior, and vice versa. For patients with extensive comorbidities, consider using local anesthesia by doing open mesh repair. For patients with high preoperative pain, consider using laparoendoscopic repair. And in active young patients, consider using laparoendoscopic approach. Femoral hernia in women, it's better to use preperitoneal mesh and especially endoscopic repair for female patient and femoral hernia. So take home message, number one, mesh is always recommended. Standard open repair is Liechtenstein. Liechtenstein and laparoscopy have similar recurrence rate, operative time, complications, but pain is less with laparoscopy. TEP, TAPP have comparable outcomes. Provide a tailored approach, both anterior and posterior approach. That's why we have this course. We have to learn both anterior and posterior approach. Thank you very much.
Thank you, Satyan. Before we move on to the last lecture for today's session, I would like to open up a discussion, especially on the lecture of Professor Satyan. Primarily because there's a lot of questions and a lot of discussions on this one. So I would like to just, move us to discussing these matters because I think this is one of the most important part in hernia surgery. Uh, anyway, I would like to start it off with Anil, Professor Anil, with regards to the choice of which one you would want to do. And I would also encourage the participants to please write down your questions, anything that you would want to answer, to ask the panelists and the speakers. Anil?
Yeah, thank you, Alan. So we've got a fairly detailed account of the sort of individualization of treatment options from Professor Satyan. And these same facts would be in fact repeated tomorrow in the session that we have on decision making for inguinal hernia repair. So we will be, I think, expanding on many of the things that that we have heard today from Dr. Satyan. And this is going to be for those two sessions that we have on decision making, both for inguinal and then on the last day for ventral incisional hernias. Do we have any specific questions, Alan? Anything come up on our chat box?
We don't have any questions yet. I just want to have a quick question to the speakers, to the speaker, and also to the panelists. There's always a misconception of TEP being hard to learn. Although in our experience, in my experience, when I first went into endolaparoscopic approach for hernia, uh, I was first taught of on how to do TEP. So I really don't understand why a lot of people would go to TEPP rather than go to TEP. But what's your comment on this one and your take on choosing between TEP and TAPP?
Okay, was that for me, Alan?
Yeah, anyone from the panelists. I'll ask
Yeah.
all of you actually.
Rolf, can you take that, please?
Yeah, I can take this question, and that is a very interesting question to me because, as I have mentioned, I'm eventually one of the guys who has been in a hernia center from the very beginning of my career as a resident, at that point of time, Schumpelik. So you can appreciate that I had to convert from Bassini to Scholdeis, and then from Scholdeis to other procedures, and then from open procedures without mesh to open procedures with mesh, and then from laparoscopic procedures, similar to Ellen, from TEP to TAPP. Now, what are the issues here? One of the issues was that when I finished my training in France, and the first repairs, endoscopic repairs for inguinal hernia, have been actually TEP repairs by Deluc, etc. So I was definitely influenced by this part, and I started to do TEP. Why I changed from TEP to TAPP had actually mainly educational reasons, because my residents later on were asking then, well, we don't understand anything when you do this TEP. They could easily follow a TAPP, as it is a little bit more, sorry to say so, surgical, because you have to cut and you have to suture. In TEP, you don't cut anything, you don't suture anything, you don't fix anything, so you only dissect, you place the mesh, and that's it. So from a patient's perspective and from a logic perspective, perhaps the best possible approach to the inguinal region. And I know that Anil and Chobi, they prefer TEP. From an education point of view, yes, you can train residents from the beginning to do TEPs, as I was trained to do TEP first. But the request from most of the physicians was, well, we are more, we like more the TAPP approach. And if you look at the figures, as I'm a German, if you look into the figures of Germany, one who has promoted TAPP in Germany to the top of the procedures done as laparoscopic procedures is Bittner. And Bittner has almost only repaired TAPP procedures, hernias by TAPP procedures. So there are many, many different aspects to it. But finally, what is the verdict? And the verdict is, yes, you should be able to master several different procedures, not only TAPP or TEP or open versus non and with mesh procedures. So if you are in a hernia center and if you are a so-called hernia fellow or hernia surgeon, then one single procedure will not suffice. If I go back to the TAPP, what are the differences in TAPP and TEP? You might have a little bit more intra-abdominal problems when you do a TAPP and complications versus more abdominal wall problems in TEP. So this will be discussed certainly tomorrow when it comes to the choice of procedure. What are the risks and the let's say the bonus and the disadvantage points for the each and every different procedure. But TEP means basically from the beginning you wanted to have an extraperitoneal approach. And more even ventral hernias, we try to keep it TEP and not to go through the abdomen for various reasons. Most of the times adhesions are one of the main reasons why we actually don't like to go back into the same mess as before. But there is no clear preference for one or the other. My recommendation is learn at least 2, 3, or 4 different approaches so that you can really, really tailor the approach for this individual patient to his best benefit.
Thank you, Rolf. Any other comments on this one? Before we go on, I would like to acknowledge the presence of our founding president, Professor Pradeep Chaubey. Good afternoon, Prof. Anyway, there are 2 questions here.
Alan, may I comment first?
Yes, please.
This is Maki. Regarding the TEP and TAPP, used to be you can actually get away with just learning one. Like you can be a TEP expert, a TAPP expert. But as Rolf said, you have to be able to tailor your cases based on this. So like me, I usually do my lap or my endoscopic hernia cases TAPP. But nowadays, I need to learn TEP as well because there are other endoscopic procedures which will benefit if you know how to do TEP, because now there's ETAP, and then we all know that ETAP has progressed from just inguinal hernias to incisional and ventral hernias. Even lateral hernias can be repaired with the ETAP approach. So if you are really going to be a serious hernia surgeon, it's not enough that you learn TAPP, but you have to learn TEP as well, and learn both of these techniques the best way you can. The key in learning both is that you have to really master the anatomy of the posterior wall.
Thank you, Dr. Maki Failona. Can I call on Professor Pradeep Chaubey? Yes.
Good afternoon, everybody, and welcome again to Hernia Essential. We are delighted, and I'm delighted to be part of it now. What I have to say is what Rolf has said, I think is very correct. And I would like to say that I think I would also like to add a third step, and that is the hybrid approach. So, you know, TEP, TAPP, and hybrid approach, and I would group them as endoscopic groin hernia repair. And in our practical situation, what we have seen We started TEP in 94, and we did not really start with TAPP. And the crux and the secret lies in understanding the endoscopic anatomy of groin, which can be done either way. And then also over a period of time, we realized that TAPP is also very, very important. And some of the cases which we do TAPP, and that is the right procedure to do rather than TEP. However, having said that, I think every surgeon will make his strong point, like any chess player, they will make a strong move. So I think then basically then they get divided into TEP and TAPP. So anybody who's more comfortable with TEP continues to do TEP, and somebody who's comfortable with TAPP continues. And as I said, we have added a hybrid procedure where you combine TEP or TAPP with small scrotal incisions or some support to remove a very large or to reduce a very large hernia. So that is my submission.
Thank you, Padu. There are several.
Alan, maybe one more point. I don't know if I made it very clear in my statement. If you do a TAPP, you have to cut, you have to dissect in the peritoneum without holes, and you have to suture at the end of the day. So we have chosen for educational reasons this because it's a very good exercise for young surgeons to learn how to suture the peritoneum, which is not the case in TEP. You don't need to suture anything except in the end, perhaps the little fascia defect at the umbilicus, but all the rest is without suturing. So for dissection, TEP is perfect. For learning to suture and to cut, TAPP is perfect. So therefore I make this difference.
Thank you, Ralph. There are several questions that we would want you to answer. And the first one is, why is tissue repair recommended for young males? I think the question goes to Professor Satyan.
Mainly because the young males still have a very long active life, and the
hopefully the old men too.
Yes, you too. Now we live into hundreds. That's why for the activity and in the future there are more chance of developing chronic pain, which happens not too infrequently, especially in the Western society. There's lots of chronic pain. So laparoscopic is the best to have the least chronic pain because you don't come across nerve too much. If you dissect exactly like Rolf said, avoid the triangle of pain, triangle of doom, then you are very safe.
Thank you, Satyan. Another question from Dr. Joel Selahe. What are your thoughts on the rising popularity of the Desarda technique for non-mesh repair of inguinal hernia? Desarda technique. Anyone who wants to answer? Rolf?
Again, can you repeat? I'm somehow, I have some problems to follow you now. The screen is moving and the voice is coming and going. Can you repeat, please?
What are your thoughts on the rising popularity of the Desarda technique for mesh repair?
Got it. Yeah, got it. I think this is a little bit similar to the answer of Satine. If you have patients who don't trust in foreign body, and these are the young people, perhaps more than the old ones, because in the old population, we assume that the degeneration of the fascia has quite progressed, and more hernias in the age are not really easily repairable. So therefore, in the old age, the mesh repair is definitely recommended. In the younger population, where you might have still a fascia available, the preference would be not to implant a mesh, because mesh has been under discussion, and you know that certain meshes have been removed from the market, etc. So there's always a little bit of discussion about the mesh. And if you look at the attorney sites of US, it's full of, do you have a mesh? Come to me, I will help you to get money. So therefore, there is an indication for non-mesh repair, and the SARDA is a technique. We will discuss it later in the open repair without mesh, is a technique which is definitely equal or eventually better than shoulder ice repair. So you will avoid to put a mesh. That's an important factor for some patients. Furthermore, meshes as such have their own problems, as we heard, and we will definitely hear more about it. Mesh infection, operations after previous operations, etc. So there will be always at least a non-mesh repair to be considered, whether you will do it or not. What did I do in the last years? I don't recall of having done any non-mesh repair for the last 5 years. So even if you go through the discussion with a patient, mesh versus non-mesh, it depends, of course, on how you present this procedure to the patient. But in my experience, most of the patients have chosen a mesh repair. In spite of all the publications on the problems with meshes. We haven't found the perfect mesh yet, or the perfect replacement yet. Whether this is a polypropylene mesh or a biological mesh or a stem cell induced mesh or covers of meshes. So the end of the story is not yet reached, but definitely we haven't discovered the ideal mesh yet. And therefore this discussion will go on in the future. But coming back to the question, what is so popular in the SARDA in Asia? Meshes are expensive, so some of the insurances will not cover. There has been a trend, basically in India mainly, to use mosquito meshes, which are much cheaper than the medical meshes to repair hernias. And therefore, you can understand that also in India, the development was pushed towards a non-mesh repair. And this is why the SARDA became more popular. I don't have a final answer to it, but I think, as Satine has mentioned, younger the patient is, smaller the hernia is, more likely you will have to consider non-mesh repair.
Thank you. There's another question here from Dr. Alex Cirillo from Zamboanga. What is the guideline on incarcerated inguinal hernia, strangulated inguinal hernia? I think the question goes to Professor Satien.
Could you repeat again? Sorry.
What is the guideline on incarcerated inguinal hernia, strangulated inguinal hernia?
The classification would be the same, but you just put down diagnosis as incarcerated. Because the size, location, and the primary or recurrence, you put down the same.
Thank you. There's a question actually answered by Professor Macario Failona in the question and answer box. So the question is, can we use the APHS classification for pantaloon hernia? And Professor Failona answered it as yes, you can just you just have to put the L and the M combined if you're using the European hernia system. Anyway, if there are no other questions or anything that the panelists would want to add, is there another one? There's no other questions from the floor. There's one more question. Let me see the order you are. So there's another question from Dr. Boji, Santo Domingo. Is the presence of moderate to severe ascites a contraindication to TPP or TP? I think it's a very good question. Anyone can answer this? If you have ascites, is there any contraindication to do TAPP or TP on these patients? Your thoughts?
I can answer that. I think for ascites, any intervention could be very detrimental and very problematic from the patient's point of view, because we are taking away the tamponade which has been developed because of the presence of the fluid. And the moment that tamponade is gone, and either you make a puncture and do laparoscopy, or you do open repair, we have seen disastrous results where the patients are referred to us with the leaking peritoneal fluid, and which creates hyperproteinemia, etc., and which is very, very difficult to maintain. I would avoid operating such patient because the presence of hernia, whether it is umbilical or inguinal, possibly will maybe because of the raised intra-abdominal pressure caused by the ascitic fluid rather than the weaker area. So it's better to leave them alone till their ascites reduces and the intra-abdominal pressure reduces by virtue of medications, if at all.
Thank you, Pradeep. I think it's a very nice discussion on the how to treat the patients. Anyway, let's move on to the program. So I think the last lecture for today is about the TEP repair for inguinal hernia, to be given by Professor Pradeep Chaubey. But before the lecture, we would like to post again some poll questions. Can we put up the poll questions, please? The first question is, TEP repair is a procedure of choice for uncomplicated inguinal hernia. And the second question is, TEP repair is too difficult for me to learn. Let's ask the participants to answer the poll. Do we have the result? Okay. So for the first question, TP repair is the procedure of choice for uncomplicated inguinal hernia. 73% of the registrants answered yes, and 27% answered no. TP repair is too difficult for me to learn.
It's 17 hours.
77% said no, and 23% said yes. Very interesting. So with that, we go on to the lecture of Professor Pradeep Chaubey, our founding president of the Asia Pacific Hernia Society. Professor Pradeep, please.
Thank you very much. Thank you for this opportunity to be discussing on this very interesting subject of TEP. And I'm happy about the poll results which have come out. TEP definitely, I would say, is a little more difficult, but one thing which can make it very simple and not so difficult is having your own team. For example, for TAPP, you can have your cameraman who has possibly lesser experience, and he will find it easier to show a telescopic view because there is a big cavity. And TEP has got a limited space. So your colleague who's helping you and with the camera, if he's an experienced person, I'm sure TEPs can be made very enjoyable. But if your younger colleagues keeps on changing, then before he learns, I think he moves on to his next assignment, and then TEP becomes a little difficult for the surgeon to do. But if there is a team, I think the TEP is, according to us, is a very good procedure. And once you learn the anatomy, which is same for TEP and TAPP, but the camera work for TEP is more difficult to do. Having said that, I think the centers which are doing TEP, their training is not a big issue because there are dozens and dozens of cases which are happening in the rapid sequence without much gap in between the two cases. When I say gap, means every week you see 10, 12, 15 surgeries, then I think the training also becomes simpler for our younger colleagues. So now we will move on to, I will share my screen and we will move on to the presentation. My greetings, of course, from our department and the Institute of Minimal Access Surgery, which happens to be very proud member of APHS and the Center of Excellence for APHS. And happy that my colleague Anil is also there, and most of you have visited our institutions, and we have interacted on so many occasions. Okay, so my first thing is that for any endoscopic repair or endoscopic surgery, it is very important that we do a thorough skin preparation. A short skin preparation without any protocol is not advisable. We prefer a clipping rather than shaving or hair remover cream. And razor shaving in our institution, we generally avoid because we have seen that it might have the possibility of increasing the wound infection, even that if it is low. So we have a formal preparation of the skin and we clip. Most of the time the clipping is done during just before the surgery. Now, pre-op preparations, of course, emptying bladder is very important. And here I would like to tell our younger colleagues that at present, what we are doing is we are asking the patient to pass urine. The patient just before taking him into the operation theater, and also our anesthetists give a lesser intravenous fluid during surgery so as not to fill up the bladder. And if you are at the beginning of your endoscopic hernia repair career, it may be a good idea to put in a catheter so that you have enough space there for this thing. For us, indication of putting urinary catheter is in very senior persons with bladder neck obstructions or prostatic enlargement, where we don't want them to over-distend their bladder and we want to keep it collapsed. We remove that catheter 24 hours later, but most of the younger patients will not need, they will just need emptying the bladder just prior to operation. And as I said, we restrict fluid during surgery so that we don't distend and cause overhydration. If any patient has got any longer expectation of a longer surgery, complex surgeries, then of course, or reoperative surgeries, I think it's better to put in a catheter because then we know, first of all, that the bladder is collapsed and we can avoid injury to the urinary bladder. And that way, I think is a safer option. Preoperative preparation, I would say, may be effective in preventing urinary borderline cases. You can give some blockers to relax the bladder neck. We don't have any study to show how it affects, but maybe if you have a little confusion, some of the patients, we start them on Urimax or something a couple of days prior to operation, and we continue that for a couple of days, 4 or 5 days after the operation. And this eases the passage of urine in the postoperative period. The patient position is important here. You see that this is the main surgeon here, and the opposite side, the hernia is on the opposite side. So like in this picture, the main surgeon is standing on the left side of the patient. Patient is supine, and the younger colleague is just opposite. And if the surgeon is standing on the left or the other way around, if the hernia is on the right, the surgeon should stand on the left. And when you want to go on the other side, the surgeon switches the position to the other side. And the monitor, we keep it on the foot end because the surgery is from upside down, in the sense that the view we want from umbilicus coming down to the iliopubic region and the pubic region. So this is one, and the monitor, of course, you can see that the monitor lies at the foot end, and of course these anesthetists. Now, if you have the luxury of having another monitor here, it is good for your colleagues to have a direct, and he can be much more relaxed with that. So this is what about the position of the patient. Now, access is slightly below the umbilicus, but on one side of umbilicus, not the true subumbilical incision, as I will show further that it has to be on the opposite side of the main hernia. So on the recti muscle. So if the person has got a right-sided hernia, I would try to prefer incision on the left recti, just below the umbilicus. Then we divide the anterior rectus sheath, make an incision, and retract the rectus sheath laterally. And of course, we access the retrorectal space this way. Now, how you can create the preperitoneal space? We preferred a balloon dissection, and the thing is very simple because we want the midline to be taken care of. We want the peritoneum not to be coming to midline because we put 2 more midline ports. Balloon dissection, I think the greatest advantage is that it is reproducible for a younger colleague. Once you get good experience, you can simply put in a finger and create that space, or you can create with the telescope dissection. But if you want to teach, and if for a younger colleagues, balloon dissection gives you fairly good reason to be sure of the space. I would like to put in one factor that we prefer about 100 cc of balloon inflation. I will again talk about it, and not beyond 150, because in some senior patients, the big enlargement of the balloon might cause injury to the peritoneum. So we prefer around 100 cc. There is another option, as you see. I don't know whether they are still available. These are the preformed balloons. They may be available in some country, but it increases the cost. Of course, there is a balloon on the tip of the cannula and the trocar, but we have got our own way of doing it, which by and large, I think we have been showing it and again for almost like more than 20 years. So it has become reasonably popular. And you see that it is a suction irrigation cannula. I will show you how to make it. It is simple suction cannula, and there is a finger, the glove, the fingers stall of the glove. So this is how we do. We take the disposable glove, and this is we tie it with a silk. We put 2 so as to make it little gentle, as well as for to prevent rupture. It gives the strength. So everything is sterile here. You see the sterility is not compromised. Suction irrigation cannula, and then you can inject with 50 cc syringe. We inject 50 cc of saline. You can have 2 fillings, and you can see a reasonably good expansion of the balloon. It's our own technique. So we are very fond of this technique, and we feel very proud that it doesn't increase the cost. So it's to make it TEP cost effective. And here also I would like you to take a look of this S retractor which is there. This is a very simple, less expensive S retractor which will be used, because if you are using vertical Langenbach's retractor, then the space given is less. With the S retractor, you have got good space to take a bite. Again, you will see in the video. Now this is the space. From here we enter the skin, go behind the rectus muscle, and then go into the preperitoneal space or retroperitoneal space, whatever you may like to call. It is this space where we will all be working. Now this is how we distend. The cannula enters here, and this is the peritoneum which goes behind, and of course this, the bowel will not come on the way, and this is a pubic bone here, and this is the enlarged diagrammatic representation how the balloon, and then we will put 3 ports, another 2 ports, one here and one here. So the role of the balloon is to separate the peritoneum from the midline. Once you have a camera in place and once you have port, I'm sure the dissection can be taken under direct vision without injuring. This is our classical placement we have the 10 millimeter port just below the umbilicus, and then we have two 5 millimeter ports. And first, we would like to tell you that this particular port is about a centimeter above the pubic bone. And this is important. If you're too close to the pubic bone, then you will find it difficult to move the instruments. So, and if you're too away from here, then these both hands, left and right, will clash. So then I would suggest that once you put in a camera port, another port which you put is just above the pubic bone, about a centimeter, which you can be sure by palpation. And then between this port and that port, you put the middle port. And this is the way we do it in most of the cases. However, for some difficult situations, you may like to put placement on this side and another this side, two on the left flank and the right flank. However, you have to be sure that there is no peritoneum underneath these, and our balloon dissection is only on this line. So you have to be careful because the possibility of causing injury to the peritoneum here is more. So sometimes what we can do is we can make one port here, and without bothering about it, we separate the peritoneum and put two more ports. So the patient may have 4 ports. I would insist that do not count the port. It is the comfort of the surgeon and ergonomics, which is very important. So just putting one midline port and then creating space for these two ports is okay with us. Or you can have one port here, and then you can have one port for suturing, etc., up, and you can avoid another port here. So this is another configuration how you can adopt. It all depends on the cases. The dissection, how you start the dissection. The first landmark which will come is the pubic bone. The pubic bone is the first landmark which you come across. And that is the shiny white structure, which looks also, and you can feel it also with the tip. So that gives you the structure from where you start your journey. So this is the starting point of dissection. Then we move on to Cooper's ligament. Then you see on the ceiling the inferior pregastric vessels. Then you start seeing the cord structures entering into the deep ring, and of course all the orifices and the fascia over it. Posteriorly, I think the peritoneum is to be reflected to the point of which the vas deferens turns medially. So this is what our dissection, and please bear with me, I'm going to show all these things on the video as well. Now, you see the dissection, I'm sure we have learned the anatomy. This is a direct hernia here. This is a direct hernia. This is the inferior pregastric vessels which are going, and this is a pubic ramus here, and this is a sac. You can see, of course, the structures on the floor, which you have talked about. On the medial side, this is the right inguinal hernia. So this is a medial vas deferens and lateral gonadal this thing. And in between this is a triangle of doom. This is the apex of the triangle, and the major vessels lie here. So this is, again, recapitulate the anatomy. So first we go to the pubic bone, and here you can see the picture. You can see this white pubic arch which you are seeing, and the raised portion here is a pubic symphysis, and this is how you should move from here laterally. So if you are standing on the left side, you move on the right side. If you are standing on the right side, you move on the left side. Then you can see the Cooper's ligament going down like this, and this is a pubic bone, and you will come across the Cooper's ligament, and then you move on to the Hasselbalch's triangle. This is the base of the peritoneum. This is the medial walls, the gonadal vessels, and to identify. So when you are moving, you will see on the roof there's inferior pregastric vessels, and you put one instrument here and keep them up. If they start hanging, it causes a problem. And then, of course, we move to the cord structure. You can see the cord structures entering into the internal ring, and that is how you identify. And then you create a inferior-lateral space. And this is the area from where our mesh will all go. And I'm going to sequentially show all those things. Now then there is the issue of how you are going to manage peritoneal tears. I think the peritoneal tear in a true sense is almost 50% patients may have, and I'm not talking of major tears, I'm just talking about maybe a little puncture sort of thing, which can, in a certain patients, it could be thin. So the tear, you should not really go, and there's a level 3 evidence that almost half of the patients may have without bothering the surgeon about those tear, and we should not really bother about them. So now you see this is a video which you see, we are just showing if there is a peritoneal tear, you see this, there's a big peritoneal tear. This is a big peritoneal tear here, very big tear, and because the bowel will come out and may cause obstruction and get adherent. So what you do is you create a space, and then you take, if you want, you can have an extra trocar placed, put in a needle, and of course you suture it because it's a very large tear at a wrong place, wrong anatomical location from where the intestines can come out. You have got a self-locking sutures, you have got loops which you can do. So this is a method of keeping it, but for small tears, I'm sure you can ignore it. And sometimes we create a large tear to reduce the bowel obstructed hernias. So we make a tear in the peritoneum, bring out the whole thing, and then suture the peritoneum. So this is the way you repair it, and this is, you can make out that's a reoperative surgery. Now, large defect hernias, you see there's a big defect. This is a very large direct hernia. Now you can see what needs to be done in that. What we do is that we invert the direct sac. We pull it inside and fix it to the bone, to the Cooper's ligament with the fixation device, so as to reduce the chances of seroma. There is another possibility that we can fenestrate that transversalis fascia or stretch transversalis fascia so as to create a space so that whenever the fluid comes into the hernial space, it comes into the extraperitoneal space and preperitoneal space. So there is no seroma formation. So these are the two techniques which we are using for formation to prevent the sort of seroma. Now in this, you will see that in a large indirect hernias, we have sutured the sac, and we leave the distal sac, we divide the sac going deep, and we suture it, and then we leave unoccluded sac, distal sac, so that the whatever fluid gets collected comes into the space, and there's no, otherwise if you close both the side, then you will have the problems. Now, clinical view, critical view, what we have to see that I've already shown, I will not spend much time on this. We should see after you completed dissection, you should be able to see this sort of view with a good space to put in your mesh. Hasselbalch triangles, I think you have to make sure that no peritoneum is going into this, and this is the sac completely separated from this. Then drop bladder 2 centimeters of the Cooper's ligament. You just make a space here in the Cooper's ligament so that your mesh goes behind the Cooper's ligament and other structures so as to get fixed in that area, not to expose the ring here. If there is a very large direct hernia, then you can make one fixation here so that the mesh does not get sucked into the direct space. Visualization of medial and medial to the femoral vein is important because we just not touching that vessels, but just to create a space or a shelf for the mesh to go. I would like to insist and emphasize on the peritalization of the cord structures. You make sure that the peritoneum is not coming in contact or not getting pulled up to the deep ring. Because if you don't push the peritoneum too much, then it may just slip underneath the mesh and go into the hernial orifices. Reduce any lipoma. Again, this is a very important point because inguinal area is known for its lipoma. in lipoma is very important because the base of the lipoma is always attached to the peritoneum. So you have to pull out the lipoma from the canal and then push it back so that the mesh lies in front of that fatty tissue. Otherwise, that lipoma will pull the peritoneum also into the orifice. And laterally, you are dissect up to anterior superior iliac spine, and fixation above the iliopubic tract is to be avoided. Minimum mesh size, I would say, though it is mentioned here 15 by 10, but I would still feel you should be closer to 15 centimeter rather than away from the 15 centimeter. Now this is a size 13 by 15 mesh. We do not like to put anything lesser than this. And this is the way. Horizontally it is 15 centimeter, and vertically the edge which is coming closer to the umbilicus is about 13 centimeter in this way. Now larger hernias, we will prefer a bigger mesh if it is possible, because we know that the mesh can shrink up to 40%, and the mesh which you think is adequate at the time of operation may not be adequate after it contracts, and it may expose various areas from where the complex, the hernias may develop. This is how we tie the mesh inside, how we pull it, and this makes us, manipulation of the mesh very comfortable inside, and this acts as a tough, stiff structure for proper placement of the mesh. And you see we have 5 centimeter of the mesh which is not folded. You see the vicryl sutures, wide sutures with the knot on this side, and 3 centimeter away from the margin. This is 3 centimeter away from the margin. Now see, this is how we fold the mesh. And we are keeping it on the sterile pack. We just opened the pack, and from there, you know that the 3 centimeter is left. Then we put it, fix it with Alice or any other instrument so that it doesn't get unfolded. And from 3 centimeter from the margin, we put the sutures. And we keep the ends long, and you see this is the mesh, 3 centimeter from the margin here, and 5 centimeter of unfolded space. And knots of the mesh is on the flat side, knot, so that when you are cutting those knots later on, you will find it easy this way. And this is the other side of the mesh, and this is how we prepare our mesh. I've shown you the balloon as well. I think, I will just go on to this larger. Post-operative ambulation, we encourage them to get ambulated as soon as possible, and early return to normal activity is our norm. Complications, seroma, of course, we will be not talking much. I'm sure it will be discussed somewhere else, that we should not aspirate the seroma. That is a message, because you can infect the seroma and cause a mesh infection. And you have the various grade of evidences which you see. And we hardly drain anything. Rarely we have to drain when we have to do an emergency surgery with patient on either on anticoagulant or on some blood thinners, and we cannot wait for 4 or 5 days for them to stop. Urinary retention is seen, should be less than 1%, but I think if you use judicial use of catheter will definitely reduce this, and we don't like to overload them with fluid. Chronic groin pain, I think I'm sure will be discussed, which you have seen more in a younger patient and a female gender. We have seen more, and we are of course very much concerned. And there are ways and means to avoid chronic groin pain. Now this is surface anatomy. I'm going to show you the video. If you see the midline And you see this is a costal margin. This is the hernia on the left side. This is the right side hernia. And you see we are just below the umbilicus. We make an incision. And you see the S retractor here. You can see the white anterior rectus sheath. Make a small nick. You can see that nick, and we lift it up. And we use the port closure needle to take 2 sutures of the upper lip and the lower lip, and these 2 sutures will be tied to the Hassan and also tied later. You see we put in a retractor. The medial border is displaced laterally. Then horizontally we put in a balloon, and this is the Hassan cannula. It can be disposable, and this is the space which you see inside. And then you start dissecting under direct vision. And once your camera is in, you have got full control of the situation. Now you see the movements are up and down. One movement, one instrument goes up, one instrument goes down. This is how you create more and more space for your camera person. And you can start seeing the inferior epigastric here. This is the inferior epigastric. Keep that inferior epigastric up. And you can see the direct sac. This is the direct sac. This is a hernial sac here. So you push it back. Pushing and pulling. You re-grasp it again, provide tension, and this goes back. This is a pseudosac, stretched fascia. Make sure that you divide everything here. Otherwise, this becomes a cause of recurrence here. So this we are sure that there's a pubic bone, Cooper's ligament, all this thing is exposed, so that your mesh will go from here behind this mesh. You have to create a shelf for the mesh. And then this is, again, you will see, we are trying to separate the peritoneum. You can see the nerves lying on the anterior rectus sheath, the psoas muscle. And that is a triangle of pain. You should not use the cautery there. You should not dissect. You should not denude the nerves. The one layer of fascia separates the nerves from the mesh. So this is the way you can sort of make sure that the mesh is not exposed directly to the nerve. And there's a sheath. Now you can see the direct hernia. And this is a stretched fascia. And we pull it up. It's a large fascia. So we pull it up and fix it up here. Either you can divide it here, you can divide it, or you can fix up to the anterior abdominal wall or to the bone with the fixation device. And this will reduce the chances of seroma in the postoperative period. The mesh, we remove the telescope, and then we put in a mesh through the telescope port. And you can see that how the mesh goes into the shelf behind. This shelf is made, so it goes behind the bone, and then we fix it up with 2 sutures, 2 clips here. And both the side mesh, we keep the mesh holding and deflate the abdomen so that not to allow the mesh to be defolded. Now, it's an indirect inguinal hernia. That you saw the direct hernia. Now you see the indirect inguinal hernia. The steps are almost the same. Maybe we would just see how the indirect sac has to be handled. Again, the lateral space which we are creating. Now you see the sac which is going in. And you have to work on this sac on both sides, lateral side as well as on the medial side, so as to remain in the proper surgical plane without causing. So this is the lateral dissection. Then you come medially, lift it up. By working on both lateral and medial side, you can go around the sac. Now you can see the sac here is going into the internal ring. And you separate from the various structures. This is a vas. You can separate from the vas. Just go around the sac here. You can see we are going all around the sac. You have to keep on changing the grip so that you go around all the surfaces. And now we are almost there. You can see the transparent sort of way you have come on the other side. All the cord structures have gone here. So if we have gone around see, this is a cord structure, we have gone around the sac. And I'm about to finish, and you see the sac, how to handle the sac this way. If you are able to reduce the sac completely, it's fine. If you're not able to reduce the sac, you can tie a ligature here. So you see that ligature going there. Make sure that there's no content. We tie it only on one side and then divide the other side. In this case, we have been able to completely dissect it. But ligation helps because it will not allow the bowel to come into the extraperitoneal space with the larger sac. So now take-home message, I think, is the creation of peritoneal space. We have already discussed. Then we have to dissect from medial to lateral. The landmarks to be visualized are pubic bone, Cooper's ligament, inferior epigastric vessels, myopectineal orifices in the boundaries, and of course the fascia on the psoas. Extensive peritoneal dissection is critical to prevent rolling of the mesh, and the mesh should be at least, again, I think I would like to change this 15 by 10 into 15 by 12 or 13, and early return to normal activity can safely be recommended, and that's how we should do it. So I'm through with my presentation, and I'm ready for any question answer.
Thank you so much, Pradeep, for a very extensive lecture. We'll open now the discussion for this topic. We encourage again our registrants, our participants to please post your questions on the question and answer box, or even to the chat room. We'll be more than happy to answer it. I think this is the most interesting part now of the whole lecture series for the next 3 days. Primarily because of we're now dealing on procedure, especially for hernia. So we'll start the discussion off on the TEP part. There's a question on YouTube from Dr. Janix de Guzman. And the question is, do you do spinal or epidural anesthesia for your TEPs? And if you're doing it, what is your experience or your opinion on doing your spinal or epidural anesthesia?
Well, I think initially, almost about 15, 20 years back, we did in some patients, and the study is published in surgical endoscopy. I will not remember the year when we published, but we did publish it. And then we started realizing that it is not really necessary to do this, because in case there is a pneumoperitoneum, the patient gets very restless and the problematic. However, having said that, we see that only contraindication for us for general anesthesia at the moment is the COPD or severe problem with the lungs and infiltrative lung diseases, etc., where we prefer to do an anterior approach under local anesthesia rather than pushing the endoscopic repair too far so as to cause problem for the patient. So we prefer anterior approach under local anesthesia rather than trying to go in for a spinal or something like that. It's only for conditions of the lungs in the chest.
Thank you, Pradeep. How about the others? Do you have any experience on doing your TEP under spinal or epidural anesthesia? Maybe Barlian, do you have any experience on this one? Barlian Suteja is the past president of APHS. He's from Jakarta, Indonesia. Barlian.
Thank you very much for your question. And to me, is the same like Pradeep said. This is Better to change to anterior approach than to push in the laparoscopy hernia repair, because this is a good way to do it for the patient with contraindication with general anesthesia. Not to do in spinal for the laparoscopic hernia repair. Is something dangerous, I think. That is my opinion.
Thank you, Bailan. Satyan, your comments? Is Satyan still here, right?
Yes, I'm here. What's your question again?
Do you have any experience on doing your TP
For the
under spinal anesthesia?
anesthesia? No, I've never done that. I won't do it because patients are not relaxed, and when get into problem, there is a problem with the too high the level of the anesthesia. It's quite dangerous for the respiration. So because of those risks, I don't do it. And I have to say also that my setting is a private hospital, so we have no problem about general anesthesia. And if I have to do under spinal, I rather do the anterior approach, which I feel more comfortable. That is personal preference.
Kuya Maki, do you have any comment on doing your spinal or epidural anesthesia? Especially for you, you're working in a government hospital where we do get a lot of patients coming in for hernia repair, and you offer either TP or TAPP. What's your comment on doing your spinal anesthesia or epidural?
I have actually no experience on it. I know it's doable, but we are a teaching institution, so if you do spinal for TABB or TEP, you have to be fast in doing the procedure. So we have no experience on using regional anesthesia for TAPP or TEP.
I like our show, Kuya Maki. Anyway, we had our experience also for doing TEP under spinal anesthesia, and we were able to come up with 100 patients for this one. But the results are quite promising, but then again, it's too tedious. And one thing that we need to watch out for also is, just to add on what Pradeep have said earlier, some of our patients would come up with spinal headache. And we have to remember that after spinal anesthesia or epidural, the patient should stay flat on bed for at least 6 to 8 hours. And these are the things that would let you think twice in doing your spinal anesthesia or epidural. It's doable. It's actually very doable, and we've done some patients with, especially nowadays, with respiratory, contraindications in doing intra-abdominal pneumoperitoneum on patients. So it's doable, but cumbersome in patients. Let's push it further away. For patients undergoing laparoscopic approach, even under general anesthesia, we've seen some surgeons giving still spinal anesthesia or epidural just for pain control. What's your comment on this one? Just to push the.
Well, I think there's when we talk of endoscopy and laparoscopic, if you have not really fiddled around with the nerves, the pain component is very, very less. I think there's hardly any. It's more of a discomfort, if I may call that. And our aim is to early mobilization. Some stiffness goes the moment the patient starts walking. So I would not add. I mean, it's not a painful surgery. If it is a joint replacement and giving supplementing analgesia by epidural, it's fine. But I think this is not a surgery which is possibly very painful. I will reduce pain by encouraging them to walk.
Thank you, Pradeep.
I agree with Professor Chaube. I think the pain level is not like intra-abdominal surgery when you deal with a lot of dissection of the bowel, whatever. And I think the local anesthetic supplement should work better only around the umbilical area or some incision, which even you don't use it, it's not that necessary. The patient tolerates very well for laparoscopy hernia.
Thank you, Satyan. If you're starting off, if I'm a surgeon who would want to start on an endolaparoscopic approach, what's the first thing that you would tell the student to learn? Would you rather have them learning TAPP first? Because TAPP, as we all know, we would have a clear view, a clear picture of the anatomy, of that inguinal anatomy, at least at the posterior side. Or would you want them to go for TP right away, just like what we have done during the early days of learning an endolaparoscopic approach? What's your take on this one?
What I have seen is that people who start doing TAPP, they will stay put with TAPP only. So there may be some struggle. You must have seen the person, our colleagues who started TAPP that way, they continue to do a TAPP. I would rather say that you have your colleague who helps you with the camera, and when you operate, he helps, and when he operates, you help. That way you develop a team and have a 30-degree telescope, and that really makes is quite good. Training should not be a big, though learning curve is slightly longer, but I think it's a very interesting learning curve. And if you keep on changing your colleague very frequently, then the chances are that you will get little hassle. Second thing, for a beginner, what I have seen, instead of concentrating on TEP or TAPP, what you should see is, as a practical point of view, the difference, the length, the distance between umbilicus and pubic bone. If it is more than 15 centimeter, you are very comfortable with the ergonomics of your ports. If it is less than 15 centimeter, so I would say that when you are at the beginning of your career, select a younger patient where you can take longer time without causing much problem, anesthesia problem. You should have direct hernias if possible, smaller hernias if possible, and the distance between the pubic bone and the umbilicus should be more than 15 centimeter. That your experience, so that you don't get a setback right from your first or second case, because that's quite disheartening for a younger surgeon. But if you follow this, I'm sure it's a very interesting and very enjoyable surgery. You see like you enjoy that, how the golfer enjoys by, hitting the ball. So you create a space and the space opens beautifully. So you really enjoy that feel. And you should reach to that level of enjoyment for surgery. That is what keeps you going also.
That's very true. I truly agree with Pradeep. Enjoying on what you're doing, it keeps you going every day, actually. Satyan, what's your take on this one? Same question, same. Hello, Satyan?
Yes.
This one. If you have a student who would want to go into endolaparoscopic approach, what would you tell them? To start on first with TPP or to start first with TP?
For teaching?
Yes.
Okay. I myself, I think that we should teach both. For TAPP, it's easier to identify anatomy, everything. Once we have that anatomy in mind and then go to TEP, it would be easier because the way I've been doing my surgery myself, I started that way. I have done pelvic surgery before, so I know the anatomy posterior before we ever have laparoscopic surgery. I did some pelvic laparoscopy surgery, for example, hysterectomy and ovarian surgery. I'm familiar with that already. So once there is TEP, then it's come naturally. It's easy. Actually, I even did the high ligation of the spermatos. I mean, very varicocele before. So we have to know the anatomy that way. So I think knowing that before it will help. But I also agree with what Dr. Chaube said, that lots of people, when they stick with the first one successfully, they want to stay. And that is quite difficult. If that case, I'm trying to think that TEP.
I think there's no volume, Dr. Satyan.
Okay. The TEP is better for the patient in the sense that you don't have to cut the peritoneum. There is no peritoneal. It takes less time eventually, and you don't have to deal with it. And so how can you teach TEP to, it's very difficult for new beginner to go into that space and learn the anatomy if they don't see the clear anatomy to start with. So I'm thinking that you have to go with cadaveric part or anatomy session first before going into that part. Otherwise, once you go and everything look red, it's quite difficult.
Thank you, Satyan. How about you, Kuya Maki? Kuya Maki is running his own hernia section now in the University Hospital, Philippine General Hospital. How do you teach now your fellows or your residents into going into endolaparoscopic approach? Do you start first with TAPP or TEP? Kuya Maki?
All TAPP first, and then once they are accustomed to doing the TAPP, then they proceed to do the TEP. And we have faculty which are experts in TEP and faculty which are experts in TAPP. So the guy who is an expert in TEP will be the one teaching the residents and the fellows for the TEP. But one thing is mandatory: you cannot do endoscopic hernia procedure unless you are already proficient with laparoscopic cholecystectomy, lapappendectomy, and diagnostic lab. In other words, you have to have the basic skills of laparoscopic surgery, the skills of bimanual movement of your instruments, as well as skills in suturing. So it's very important that you know how to suture.
Thank you, Kuya Maki. How about you, Anil? Anil wants to be called also Kuya. Kuya Anil.
Yeah, Kuya Alan. So yeah, I've been following this conversation, quite patiently, and it's quite surprising that that senior surgeons, at fairly senior levels, are still divided about, what sort of training comes first, whether one should come before the other, or the way that it should be. Now, it's been about 30 years now since people have been doing endolaparoscopic hernia repairs. And one thing is very clear: there are no set answers for this. People still believe differently. So well, each senior surgeon has his own point of view as to what needs to be done. Now, if you ask me my point of view, again, to add to the confusion, my point of view is that, switching from TEP to a TAPP is no big deal at all. TEP surgeons would, in fact, fall back to a TAPP on several occasions when they are operating. But the reverse is not true. Okay, TAPP surgeons, would not that readily be comfortable doing a TEP repair. So when you're starting off, why not go the whole hog, learn the anatomy, the way that this is supposed to be learned, which to my mind is via a TEP repair. Because like I say again and again, once you know a TEP repair, a TAPP repair is no big deal at all. So, but then having said that, like I say again and again, TEP and TAPP should be regarded as complementary procedures to each other. They are not rivals to each other. So it's not TEP versus TAPP. It is TEP and TAPP. Because like we will see in our session tomorrow on decision making, there are several times that one needs to in fact start with a TAPP repair itself, which we have seen on so many occasions with our own practice. Though we like doing TEPs, there are situations where you in fact need to approach a patient with the TAPP approach. So you in fact need to know both. Right at the end of the day, if you in fact want to take up hernia seriously, you in fact need to know both. It's as simple as that. And TEP should be considered definitely conceptually superior to a TAPP for the simple reason that you are not entering the sanctity of the peritoneal cavity. It's as simple as that. Thank you.
From Barlian, Barlian is running a hospital in Jakarta, one of the biggest private hospitals in Jakarta. How do you do your training with your fellows and your residents, Barlian?
Yeah, we do because I'm a TAPP guy, since the beginning. Yeah, because we have learned from Professor Bitna at the beginning, and I stay with TAPP. But we teach both. At the beginning, we teach the TAPP, and also after we familiar with this, after 2 or 3 cases, we can switch to the TEP and both. So we begin with TAPP.
Thank you, Barlian. There are several questions from the participants and also from YouTube. Let me read the question. Okay, one from Dr. Gregorio. Would like to ask advice regarding a persistent seroma post-TEP hernia repair for a recurrent large hernia with previous open surgery. Patient underwent aspiration already against advice, but still with persistent seroma formation. Serial ultrasound done showed stable volume of fluid. Thank you. From Dr. Antonio Gregorio.
What I would like to suggest is that, first of all, as I said, aspiration is not an answer to that. And if at all, if the seroma is so consistent, and I'm sure it will be very thick walled, then given a choice, I don't know how long back the surgery has been done, but if it is quite a long time, then I would like to make an incision over the seroma and remove it in totality, including the wall of the cyst, rather than keeping on aspirating or draining, because the wall becomes too thick and it will not collapse. So it is better to excise that wall, which is ultimately the hernia sac, distal hernia sac. So it is better to divide that rather than keep on sort of draining or insisting on the somehow to collapse it, because with the thick wall it will not collapse.
Thank you, Pradeep. Any other answers or suggestions from the panelists or from the lecturers? There's another question here from Dr. John Advincula. how do you manage post-operative pain from possible retained CO2, especially after TAPP, aside from giving analgesics? Is there a way to have the body reabsorb CO2 faster?
Yeah, I think in these situations, if you're talking about the carbon dioxide, so there must be surgical emphysema, right? I think so. These patients should not come out of the operation theater. In fact, if you give 15, 20, 30 minutes to your anesthetist, they will hyperventilate the patient and get the carbon dioxide into the system rather than, shifting a, patient out of the operation theater with surgical emphysema. It's always better to let the surgical emphysema settle down in the operation theater by the anesthetist doing the hyperventilation. Not difficult.
Thank you. Any other questions from the floor? I think there are no more questions. One last take on this one. If you have a patient coming in and then the patient is for surgery, what's the first procedure that you'd want to suggest to your patient? I'll take first the answer from Professor Pradeep Chaubey.
What exactly is that? Two surgeries?
If you have a patient coming in, first surgery, what would you suggest for the patient to do? TEP or TAPP?
TEP.
TEP. How about you, Kuya Maki?
No. If there is a obstructed large hernia, then I will go in hemoperitoneum, reduce the hernia, and in our center, we will, as we are more comfortable with TP, we will go out and do TEP. That is our combined approach.
Uncomplicated hernia coming in. How about you, Kuya Maki? What would you offer your patient?
Oh, I'm a TAPP guy. So TAPP.
Barlian, I think I know the answer of Barlian. Barlian?
Barlian is also same.
Yeah, my answer is CFPP. But yeah, depend on the patient. If the elder patient, like Pradeep said, we change to the local anesthesia for the anterior repair. Yeah, but for the general, I suggest patient for the TAPP.
Prof. Satyan?
TEP, first choice.
Yeah. Okay. I won't ask Anil anymore. I just call on Anil to close today's program. I would like to say before calling on Anil to thank everyone, especially the lecturers, for coming in and all the participants for joining us. I'll call on Anil now to close the program. Anil, please.
Yeah, thank you, Alan, and would like to, in fact, thank our faculty for the time that they've taken to be with us this afternoon for this training session. And I'd like to thank our participants as well for being a patient lot. We have in fact noticed that we've had about the sort of complete set of participants with us right through the course since we have started. So for us, that's a very good sign. That talks of a committed bunch of young surgeons. We will have a mixed day tomorrow, which means we will have both the sort of groins with the anterior abdominal wall issues tomorrow. So there is going to be a mixed day. We start at the same time tomorrow at 4 o'clock your time in Manila, which is 1:30 here in Delhi, and I don't know what time in Thailand and in Dubai. But we in fact hope to finish on time tomorrow, Kuya Alan. Tomorrow we finish at what, 6:30 your time, 6:30 your time, 2.5 hours. So we shall try and save 30 minutes off tomorrow, because there is a third day to follow. So
just a reminder for the participants, if you have any questions, please write it down on the question and answer box. For tomorrow's session, we made a WhatsApp group, including all the participants. If you have any suggestions on how you would want the program to run, please type it down on that WhatsApp group so we can, try to consider it, and let's see how we can improve the presentation. Anyway, Rolf is quite busy. He has another meeting. So in behalf of the president of APHS, we would like to thank everyone again for coming in this afternoon's session. So we'll see you again for the next 2 days for you to have to be able to get the registration, the certificate of the registration for this online course. For the YouTube listeners, we will again give this online course the next time. We'll give you, if you want, you can email us using the Secretariat of APHS or the Secretariat of PICAS. She'll be included in the next future courses for the Hernia Essentials program. Please email us if you have any suggestions. So that's it. We would like to close the program now. Thank you. We'll see you again same time tomorrow. Good afternoon and good evening. Thank you very much.
Thank you.
Bye.
Thank you, Satyan. Thank you, Anil. Thank you, Kuya Maki. Thank you, Pradeep. It's so nice to see you. Satyan, thank you. And of course, Rolf. Anything more? For the participants, please check your links. We'll be still using the same link for tomorrow. For the YouTube, we'll give you the link for tomorrow because we can only get the link once we go live tomorrow. Thank you. I think we can sign off. Thank you so much. We would like to thank the back team of PICAS, the IT team, Cherry Lou, Dr. Canyones, and Alex for supporting us again. And of course, we would like to thank Medtronic for supporting APHS Hernia Essentials always. Thank you.